yours. The floor is yours, Marg. Thank you for part two.
Thanks, Carlos, and thanks everybody for turning up again. It's always nice to have people turn up on day two. I'm going to share my screen pretty quickly and keep it shared for most of the session. But just before I do, oh no, I'll do it right away. I wanted to start the whole session with a comment from last week. Ali just asked how much I thought we might need a women's health physio on the team. And, to be perfectly honest, with the referrals that Carlos had sent through, the typical referrals you might get for chronic pelvic pain, I truly thought you had someone on the team. So I structured my whole talk around that. But I had to think during the week. In fact, I thought quite a bit about it during the week. And I just wanted to, I was thinking about how much we, as people who treat chronic pain, actually say, and we say we treat the pain, not the diagnosis, but how much we actually do. Do we really need to have an understanding of the causative factors, the original source of the pain, or are we truly treating pain? So that's where I'm starting with today. And I wonder, for those who've been able to listen to the recording or have seen the case study now in typed paper and looked at the triangle assessment again, excuse me, what's your opinion on this? Do you think you could treat, say, this vulvodynia case without being a women's health physio? What help might you need if you think you need help? And no, do you really treat the generic pain, or does it become a gynae issue as well as a pain issue? Any comments?
I've got some comments. So I actually did a triangle just this morning. So I did the biopsychosocial, yeah. and I sort of did the original, which was like Lester's sort of Lester's one, which is the central modulation, the peripheral or like the regional factors, as well as the local factors. And I thought that, she probably, if we look at the central, the regional and the local, I thought that there was some peripheral stuff. There was probably out of maybe mild to moderate peripheral stuff. The central modulation, she had no trauma background. She had anxiety and depression. She was sort of wound up a little bit and quite a bit of a stressful person. But central modulation factors probably were like minimum to moderate. I think that there was a lot of local factors, so like the biological. So I actually thought you were going to go a different way, Mark, where you were going to show us like the complexity of the biopsychosocial, but actually this person was, for me, very heavy on the local factors. And I really liked your last page where you actually gave a working diagnosis of, vulvar pain syndrome, vulvodynia, dyspareunia, bowel dysfunction, urinary symptoms, that sort of stuff, because I think that, it's probably very much like the diagnosis is probably the best way to make a difference to this person. I don't know if that's what everybody else thought.
Any other comments?
I think that they all hold value personally. Diagnosis as well as treating pain by itself. And I also think that if I was faced with that person, I'd have a good red hot go at helping her, but I'd also draw in as many other people as I could, because I think that the points of the triangle need addressing. Yeah. And I'd draw in my trusty psychologists and my trusty physios and I'd say, let's do it all together, because just like every other pain person, we are better at helping them when we all help together. That's how I feel.
Oh, aren't you wonderful? Obviously, pain team people. That would be the perfect answer.
Well, but I just feel like I'm pretty hopeless by myself. I do a small piece of the pie, but we are so much more powerful as a group.
Totally. And I think, Carlos, you've done a brilliant job of going through it yourself and finding what I thought people might find. And if everybody did that same exercise that Carlos did, we might find that we have different items at each of the 3 points of the triangle, but still we would have really good structured items and factors that we could work on. And my overall belief is that although we say we treat pain and we can give it a red hot go, there are some details in there that really require local skills. So that's the way I'm going to treat today. From last week, you've had a look at the case study. The written assessment is long and detailed, and that's a sort of assessment you would take. But translating it to the pain reasoning model, the triangle, does sort things out, and the patient can look at that and make a reasoned judgment about what's important to her. So while we shouldn't hang on, I think, to the original diagnosis, we should treat pain, because that's why the patient has come to you after years and years of unsuccessful treatment of her local gynecological disease. She needs to be treated as a pain patient. But there are some things which you'll find out in the next half an hour that we probably need a women's health physio for. So if we go to the next slide, this is what we finished with last week, the clinical reasoning. We've only had the 2 hours together, so I've ignored screening altogether, because you will have probably the EPOC or something like that in your hospital where you'll have your own screening tools. We focused on assessment last week. We were given a diagnosis in the case study of vulvodynia and bladder and bowel issues, etc. So today it's the treatment. And let's look at what we can do as a pain team and where you might need a women's health physio. So if we're going to formulate a treatment plan, we understand, and I'm not telling anything you don't know here, that chronic pelvic pain causation and treatment theories are changing, and as we know more about what happens in the brain and more about the pain neurotag, that there's no pain center in the brain, of course there's going to be all sorts of theories around what about chronic pain. As far as conservative treatment goes, there's little level 1 evidence to support any singular or monotherapy for this. And that's obvious because we have a pain neurotag. Pain is everywhere in the brain. So most of the research, the current research, focuses on pragmatic treatments, a bunch of treatments together that we use rather than monotherapies. So we do have a wide range of therapies at our disposal, and that's what we're going to look at next. And there are no recipes, therefore, because of our pain reasoning, because of the pain neurotag way we look at things. But there we have some predictors. And 3 of them I've written here. There are more, but these 3 came to mind immediately. Particularly if we have a really biopsychosocial framework in which we operate. We need to have the patient there with us at the right time for them. So many chronic pelvic pain patients come to us, whether it's endometriosis, they've had painful periods ever since they were 13 and they started them, and they've been trotted around everywhere. Or vulvodynia, they've had multiple episodes of UTIs and thrush, and they've had all sorts of treatments, and they finally come to a pain specialist. Are they ready to change, or are they still in their very biological medical model that they're not really ready to change the focus to conservative therapies for pain? So we have to address their readiness to change, and there are formal readiness to change scores that the psychologist in your team can help you with, but often just finding out about their knowledge of their problem is enough to give you an indication as to whether they are ready to change or not. Do we have the right clinicians? Yes, you're a pain team, of course you are. So you're the right clinicians and the right treatments, and that's where you need the patient's own stated goals. And we had them in the case study. She wanted to understand her pain, to learn some strategies to manage her pain, to be able to have penetrative sex again, and to exercise without pain. So we are going to follow treatments that we're going to give her strategies to treat her goals. So we've got a big toolbox of conservative therapies we can utilise. And I'm going to go through them quickly on this slide, then take each one in turn. And if you want to ask any questions anyway through this section, this is your, please don't just wait till the end, but ask at any time. So of course, we always start with education. Number one, we have lots of evidence for starting with education. And lifestyle modification is easy. Well, it's simple, but it's not that easy, because simple things aren't always easy. We've got cognitive behavioral therapies, we've got exercise, we've got our local manual therapies. In the pelvis, we've also got all the other systems that sit on the pelvic floor, urinary, genital, and gut, that require some training. And then we've always got our gadgets, our adjunctive therapies. So let's take each one of these in turn and see how we go. First of all, education. I think one of the big problems is when we see a patient for the first time and they have been through years and years of medical management, that they come with a firm set of beliefs about what's wrong with them, how it started, and it may have been ingrained by the previous clinicians that they've seen. And so they come with beliefs that they think their own are the best. We meet them, we have our own beliefs. All the unconscious biases we carry around with us, and we think our own are the best. So as long as we keep that in mind, we can adjust our education to what's going to really work, not what we believe we want to teach them. Okay, so we take away the top-down approach. So we educate patients to their goals, and that may mean that you're teaching really different things or teaching the same thing in very different ways to all of your patients. So in terms of what education might be needed for pelvic pain, we don't just need pain, it's about the neuroscience of pain, although that is required. We also need to talk to our patients about normal bladder function, normal bowel function, normal sexual function. In this case study that we're talking about now with vulvodynia, not being able to have sex is one of her biggest things. And no, she's a healthy 25-year-old, should be enjoying sex to the maximum of her age. So we need to be able to talk to her about normal sexual function, not just the mechanics of penetrative sex, but all the other aspects of sex, like intimacy and libido, orgasm, etc., so that we give her a full education around what might be expected in her own sexual function. We also need to teach our patients the roles of the other multidisciplinary team members, so that each one of us doesn't try to take on everything. Just like Ali said earlier, we need to respect everybody else in the team and make sure that our team does work as a team, that your team meetings are all about the patients and getting the best outcomes for the patients. So think about your skill set now and what education you feel comfortable talking about and where you might need assistance. That's each one of you individually to think about. Okay, let's go to this patient with vulvodynia, lifestyle modification. When we look at her assessment, and when we look at the triangle, we notice that she's got tense posture, apical breathing, and the physical assessment, which I will put up shortly. I've modified the triangle and put some physical assessment factors in as well. You can see that one of the first things that we could help her with is some global down training. Teach her some open postures. Uncross your legs, uncross your hands, let your shoulders go down and back. Breathe down into your tummy, all the stuff that you would know and do anyway. And that's global. What we've got to do, though, and I've had so many patients say, I had another physio, a Musk physio, talking to me the other day saying, a friend of ours went to a pelvic floor physio. She's got problems with endometriosis. And, all they gave her was relaxation and breathing. That's poor education on behalf of that physio, that she didn't link the down training, the relaxation with the assessment, and didn't link generalized down training with the pain as a whole, chronic pain. So yes, we would start with that, but please link it back to the problem. Now, this patient has constipation. The first go-to thing that everybody does is, oh, take more fibre, get some Metamucil, drink more water, all those things. But constipation isn't just diet. I've put here the way we teach constipation at uni, the 5 C's, going from the brain right down to the pelvic floor. And now we have a very strong brain-gut axis. You know, we feel it in our gut, all those sorts of things. So if we haven't calmed down the brain and got the brain thinking more calmly about the bowel, we're going to get nowhere with our Metamucil or our Coloxal. So we start again with these global down training. It's going to assist constipation as well. We may not be able to do anything about the bowel. There may be some peristalsis problems that are out of our conservative management control. We can certainly give some dietary advice or send to a dietitian. The anorectum may be fine, or there may be some stretch occurred over time because of constipation. And again, that might be an area that's not our scope of practice. But particularly for us as pelvic floor physios, control of the pelvic floor and sphincters comes in, and I'm going to talk more about that in a slide or two later. She has frequency, urgency. She doesn't have incontinence. And these symptoms are two of the three, a syndrome called overactive bladder. Now, overactive bladder is complex. It's a cluster of causative factors, and it's not a simple thing like it's just the anxiety. Sure, we all know about nervous bladders. Now, anybody who's gone for an exam or an interview that goes to the toilets 5 times before they do that. So she's a nervous, anxious person. So there is probably a large, or maybe, I don't know, an element of anxiety there, but it certainly needs investigation. And one of the simplest investigations would be to ask the patient to do a bladder diary, in which case you're going to need to know how to interpret the bladder diary. Or it may be something that one of your women's health physios chimes in on here and is able to organise her to do one and then read it correctly. And dyspareunia, the lifestyle modification that comes with her sexual problems, might be to talk about how to still remain intimate with her partner, although this girl is just starting at a new relationship, how to enjoy the intimacy, but without needing to have sexual intercourse at this stage until she feels she can. You don't want her to be so fearful of sex or what might happen on a date with her new beau that she pushes him away or pushes intimacy away. So be aware about the lifestyle things you can talk about with dyspareunia or painful sex without actually having to give her specific education around positions to use or lubrication to purchase or anything like that. But you can, if you have another talk from a women's health physio about that, that might be something that you could do another day, or send this patient to your women's health team. Any questions on lifestyle? Okay, I'll move on to number 3, the cognitive behavioural therapies. Now, these are the strategies to challenge or change unhelpful behaviours and beliefs. So how do you feel with these? Do you feel comfortable about helping someone to develop their own personal coping strategies? I'm sure we all are, and they would come out of the conversation that we have with our patient. Things like, saying that you are bigger than the pain, giving them functional things, and that's on the next slide, to manage the pain, and to help her set goals and to set the small steps that move her towards her larger goal. In physio, I guess our scope of practice would be very much on the relaxation and the mindfulness component of behavioural therapies. whether it's body scanning, postural change, breathing, and just full body relaxation as well. For the other physios in the team, do you feel comfortable with anything I've missed out on there?
Mark, I reckon I probably wouldn't feel comfortable with the mindfulness and relaxation, but I probably do challenge a lot of, the person's, unhelpful thoughts. So I tend to be, working in that space rather than, do sort of like body scans and relaxation.
Okay, fine. So we each have our own personal strengths. Mine happens to be in the mindfulness relaxation sphere. Yours is in the challenging sphere. And that's, as we say, they're all perfectly correct and wonderful. Mm-hmm. Anyone else? Okay.
I guess I'd just add that I think acceptance comes nicely into CBT as well, and links nicely with pain education, and can be a way, like you can kind of put them together as really like one of the justifications for undertaking CBT or acceptance-based strategies like mindfulness as well, as a coping strategy, but also as a potentially a pathway for reducing people's pain as well.
Oh, I totally agree. And I should have put that there. Absolutely. So acceptance is a really, really big thing to get, that you're not fighting it all the time. You're right. It's almost the first step towards change, isn't it? Thank you for those. Okay, so exercise and physical activity. For physios, this is our home base. This is where we feel comfortable. And we use the mantras of motion is lotion, exercise is medicine. But we start off with assisting our patients to reduce the fear of movement. In our patient, we're talking about pelvic pain here, to reduce the fear of pelvic movement. And so those fear reduction movements are the rhythmic, simple, meditative, automatic type movements, and allowing breath to come easily, forcing the breath when they're doing anything. So one of the things I like to do with every single patient, and I'm going to get you to all stand up. This is an action part of this session. You're going to do some pelvic rocking, some forward and back pelvic rocking. Can you move your pelvis independent of your lumbar spine and of your legs? Can you flatten and arch your lumbar spine, if they're the words you'd prefer to use? So gently, meditatively relaxed, without strain, rock your pelvis. Now, I'm not going through all the images to see that you're all able to do it, but that's one you can practice if you found it difficult. Stay up, don't sit down, Carlos. What about side to side? Can you hip hitch side to side without moving your shoulders or head or anything? Just a bit of a hip hitch. And no lateral shunt. It's an up and down movement like a seesaw. Okay, and what about circling? Do a big circle with your pelvis. Knees bent, feet apart, so that you've got plenty of mobility within your hips. Back the other way, because we always do our dominant way first. Yeah. So some of you have had a bit of difficulty with that. Others have found it really easy. So just shake out. Because the other one that I really like to start people on is for them to stand in a semi-plie position, knees bent, hips, feet wider than hips apart, and simply rotate. Let the arms just flop from side to side, so that they're moving almost automatically. Spine, pelvis, neck, arms flopping. And you can all do that one easily. Right. Excellent. Sit down. And I'm sure each of you have your own favourite ones, but for the pelvic movements, doing the forward, backward rotation, the side to side and the circles is basic to just about anything we ever do in the pelvis. And the forward and backward motion is really sexual motion too. So you want to get the patient to be not fearful of moving their back forward and backwards. All right, so specific pelvic floor muscle exercise, and particularly down training. Now, I'm just going to change my screen sharing here to the triangle assessment, which at the bottom I did some physical assessment. I added to last week's triangle, but I did it very messily. So what's below the blue line is the physical assessment. So in the local areas, the patient had perineal and pelvic floor muscle overactivity. She couldn't contract or relax her muscle. It was held rigid. So that, and she was also irritative because she had pain for 10 minutes after that palpation. Also in the physical assessment, it was found that the abdominals and glutes were overactive, and she couldn't relax the abdominal muscles, and the glute muscles were weak. So we've got some really easy muscular activities that we can institute right away that are going to make a difference to her. But for this group, if you aren't skilled or haven't been trained in doing an internal intimate examination, then this is where we're going to start having problems, because you do need to do a full pelvic floor muscle assessment to understand what the pelvis can do and help the patient contract and relax. So let's think about if you had no access to a women's health physio, but you still felt that you would like to do something for the patient. Once again, I'm going to get you to do it on yourself. I want you to sit back in your chairs. For those of you who are sitting on a desk chair, I'd like a firm chair. If you're sitting in a couch, you might have to come right forward to the front of the couch, because I want you to sit on your perineum. Girls sit on your vaginal area, boys sit right somewhere around behind the balls, somewhere there. And sit with a fairly erect but not tight spine. Now, the way to get your pelvic floor muscles, to understand whether the pelvic floor muscles are working, is to have a sense of lifting up away from the gusset of your undies and then back to the supporting surface without moving hips, legs, squeezing your eyes, tightening your chest or anything else. Just a simple lift away from your underpants or the chair and then back down again. One more time. Lift, hold, and feel the release. With a patient who's got overactive muscles, it's the release that's important. They can usually switch their muscle on really easily, but the release is really sluggish. So, okay, you can, that might be a way of at least introducing the sense of tightening and relaxing around the painful area. But much better if you can do an intimate examination and have a full muscle assessment. But that's a starting point for contract, relax, for tightening and letting go. And the same with abdominal retraining. How do we know that the patient is not being able to let go? Of course, we do contract, relax. My go-to with this, and I'd be interesting to see what other people do, and you can talk about it in your team. I teach the yoga breathing breath of fire. Now, I don't know what its proper yogic term is, but I use breath of fire because it's like using your abdomen or abdominal muscles as a bellows, as you would, and the air comes out of your lungs as you would be to light a fire. So each of you sit tall. I'll stand just so you can see. Hands over around belly button area. And the idea is to suck the abdominal wall in, horizontally in, away from your hands, and then release back to your hands. Suck in and release back to the hands. I'm sure you can all do that quite easily. But to do it with force and speed and relaxation, you start then, without even thinking about your breath, to feel air is coming out of your mouth. So I'm doing it sitting down now, and this is what it would sound like. So you just can. Do you want to have a go? All of you, just put your hands on your abdomens and pull in and hear the air coming out. You're not breathing in, it's an out breath, it's bellows. So make sure it's a horizontal indrawing of the whole abdominal wall. We're not thinking transversus, anything fancy like that. This is just contract, relax of the abdominal wall. Once again, you can't breathe, do diaphragmatic breathing. You can't do any sort of other sort of breathing if you can't relax your abdominal wall. Not much use saying breathe deeply into your abdomen and feel the abdomen rising and falling. They may be able to do it and at that slow pace, but not functionally to get contracted, relax, etc. So abdominal retraining, down training and relaxation, I like to work with the breath of fire. And then I'll go moving on to muscle stretching or whatever you find in your assessment. And in this this assessment, there was lots of stuff through the lumbar-thoracic spine that would give us heaps of stuff to go to. But again, make sure you make the patient understands why you are doing it. That oh, I went to this physio and all they did was do my shoulder stretches, but I went with vulval pain. I can't have sex. What's all this other stuff about? So it's always linking it back to her goals and her problem. So let's think about what's happened next. Let's think about manual therapies. I think with manual therapies, it's important that we take care not to reinforce that the issues are in the tissues. Because good hands-on therapy will make the patient feel better for a while. They love a massage. They love some trigger point work. They love all those things that are done to them that make them feel good. But of course, we all know it creates dependence. So if I find something that does make the patient feel good, then I teach that, to teach the self-touch and the self-stretches, particularly of these perineal and pelvic floor muscles. So once again, I think we come back to, yeah, we're going to need that women's health physio again. If there's any pelvic floor overactivity at all, we need a very skilled and targeted self-touch and self-stretches. If she's ever going to have sex again, she needs to be able to relax the area, to be able to touch her vulva, to feel what it's like to have different pressures over different parts of her vulva, so that when someone else is doing the touching, she's not recoiling in fear. So manual therapies, yeah, do your stretches, do everything, but link it back to her goals and her problem. So specific pelvic floor dysfunction strategies, and again, here we come to the province of the women's, men's and pelvic health physiotherapist, because we do have to think about, not with this patient in particular, I don't think, trauma-informed care. If there has been previous childhood trauma, sexual abuse, physical abuse, bullying, anything like that, then it has to be done so sensitively within understanding of what trauma can do for a lifetime. We've had enough stuff on the news about lifetime problems of childhood abuse. So if someone at age 25 is coming to us, we need to sensitively find out what may have happened to them in their childhood. But if it's a repressed memory, then we don't want to force it out, but just make sure that all the activities that we do are informed by the understanding that there might be some trauma behind it all. So from that, let's go right down to the local skincare for vulvodynia. When you've got a skin, a vaginal entrance problem, there has to be some skincare. So we need to know what whether it is truly trophic changes in the skin, what creams, ointments might be useful for it. Does she need a barrier cream over her skin to protect it, particularly for her exercise? She gets sweaty and it starts to rub and she gets friction. So maybe she just needs something as simple as a barrier cream, like nappy rash cream over her skin. Good for babies, good for adults too, to help her with her sweatiness for exercise. Maybe we teach her to put on an ice pack or a cool pack over her vulva before she does exercise, so the whole area is cooled down. Then apply a barrier cream, then go to exercise. Change the material of the clothes that she wears, that she doesn't wear the tight leggings, or if she does, they are actually the expensive ones that do breathe, so that her vulva and perineum does breathe. So it's a whole lot of things like that. And to prepare her for sex, maybe talk about different lubes that she could buy that she might like to try. Some of them might irritate her skin. She might like a water-based one or a silicone-based one. So there's lots of skincare things that will help her, and she'll feel that that's getting right to the nub of her problem. Bladder and bowel management, we talked a bit about that before. So there is more that I haven't talked about, but that's, again, once you need to know what you're doing when you're dealing with bladder and bowel issues. And then, of course, the pelvic floor muscle training. So first of all, you do the down training to make sure that she can at least contract and relax and feel her pelvic floor. But most commonly, and like the gluteals in this case study, they were perceived to be weak as well. So that is exactly what happens, as we all know, that as soon as you've got some minor overactivity in a muscle, over time that muscle is weak as well as overactive. So we need to introduce some pelvic floor muscle training only after she has good management of her pelvic floor. She can contract and relax voluntarily. She knows what she's doing. And we just need to do it enough to get to her functional goals, that she can relax during sex and she can relax while she's exercising, so that it's not pelvic floor muscle training for its own sake, it's for a particular goal. So once again, think about what your skill set is and where you might need some assistance. And then the adjunctive therapies, the gadgets we have there are many. So it's a choice of when you're going to use them, what to use, and are some better than others? We have evidence for all of these. So starting at the top there, that's a set of dilators. And you can see the difference in size. Now this case study, the girl could not even have the physio insert a digit. So that means her muscles have just spasmed so much around the vagina that nothing is going to go in. In some cases, this has a sub-diagnosis of vaginismus, and that hasn't come out in this particular case study. But you wouldn't want to be introducing anything rigid, silicone-like into her vagina until she was willing to let go her muscles. Otherwise, she's just going to spasm up again. So a lot of women say, oh, yeah, that's what I need. I've seen the dilators. And in fact, I think this girl on her page 1, I think she said that she had tried dilators. Maybe she didn't. Maybe it was somebody else. But they tried dilators, got them off the web, and found they just couldn't do them. In other words, they didn't do it mindfully. They didn't do it with understanding. So the when to use dilators comes after the patient's got used to touch on the skin around the pelvis, and then the ability to let go. The other devices, starting from the bottom left, is one called the LV. It's an intravaginal device, but you can see by the size of that bulb, that's not going to go into this woman's vagina at all, because she can't even handle a finger. But there's plenty of these devices on the market if you want to learn about them at some stage, with apps Bluetoothed onto a phone to look at how the pelvic floor works. The middle picture is of vaginal weights. Now you think, how are you going to strengthen a muscle that is internal? Well, you insert tampon-like devices that have, you can see the different weights that you can insert inside them, and the patient can then do weight lifting. Is she going to be ready for this soon? Probably not, but it would be good if she could do this later on. That would be really, she'd have a really good understanding of her pelvis by then. And the two devices are two NeuroTracks, which we probably had in our undergrad days, one a STIMS machine and the other a biofeedback. The difference in pelvic pain would be that you use a pain setting on your STIMS with an intravaginal device. And I've got an image there of an intravaginal electrode. So again, when to use these? Not until this woman has the ability to manage having anything inside her vagina. You can do some biofeedback once she's got, she can handle any intravaginal device to see if she's relaxing fully as well. So these one's for stimulation for pain reduction, the other biofeedback for relaxation. One of the good things, I know it's a monotherapy e-stims, but as part of a package, bladder pain is very often very well managed with external electrodes just suprapubically, about probably about 2 fingers width apart, sitting directly suprapubically on either a high hertz pain setting, or even a counter irritant 10 hertz or below, to act as a counter irritant to bladder pain. So if she's struggling with her bladder issues, that might be something that you could use with external electrodes. So we've now gone through the 7 categories that I started with, and we are nearly at the end. Now, I just wanted to point out before I go to the last slide that these 7 categories aren't universal categories. I just made them up for this lecture. So don't think that this is, if you feel that there was a bit of overlap or it didn't quite fit, feel free to change them. It was just to make sure I got everything on in this short lecture. So we finished with some discussion. So I want to hand over to you. And I want to ask you, along with what comments you have to me, what further information do you need to treat these vulvodynia patients or chronic pelvic pain patients? Now, we can talk about that now, but that might be it can be continued in a staff meeting as well, and find out where your gaps in your service are. And I want then for you to see if you can fill those gaps, however you can do in public health these days. Ideally, more EFT in your pain team, but that might be just asking for the impossible. Still, if you don't ask, you don't get. And finally, to utilise all the networks you've got in Eastern Health for best management, I guess, is in the end what you would be doing. So over to you. We've got about 5 minutes left, or 7 minutes, depending on when you have to rush away. Have you got any questions? Do you want further clarification on anything?
Can I say something? I'm Michelle. I'm one of the OTs in the pain clinic. I think it's been a fantastic presentation. I think it's really nice how you've sort of gone through all the different aspects. It's really helpful for me to kind of start to think about, okay, what do I feel comfortable with? What is part of our already normal practice in terms of, assessing readiness to change and things like that, but also identifying what's beyond our scope, what's beyond, my scope of being an OT in the pain clinic and going, okay, this needs to be referred to physio, and specifically a women's health physio. And I think it'd be really good to be able to link more closely with the continence team or a women's health physio, because I feel like we are definitely sort of, lacking in that area in our team. Because some of these things, like, obviously internal exams and, some of those very specific bladder and bowel training and stuff like that, it would be great to have access to to that within our clinic for some of those patients.
I couldn't agree more. I think if I had vulvodynia or chronic pelvic pain or those about any sexual problem, I'd like to go to someone who really had the tips and tricks, not just the general knowledge, but the tips and tricks for the very local treatment. That end of that point of the triangle needs to be addressed.
Because I know that I've referred people from our pain clinic to the continence clinic to see the physio, but often that's because they've also got bowel or bladder issues, not specifically for pain or pelvic pain. So it's really been like there's the chronic pelvic pain at the women's clinic, that clinic there. But apart from that, there's not sort of anywhere at Eastern that I know of that we sort of refer locally to. Carlos, do you know?
Those are probably the two. Oh, am I on mute? Those are probably the two that I know of. Maybe we can ask the women's health physios that are here. So we've got a few from different areas. And I think that Vanessa's going to be unmuting herself in a second.
Hello. Sorry, I joined very late. I got a bit caught up. But yes, unfortunately, it is a gap that I think quite a few public health services do have, that gap between the pain management and the continence services, because technically our referral criteria, so people do need to have a continence issue to come to the continence service, but obviously there are pain patients that don't. Now, if someone is referred with pain, we often get sent an email from the access unit to sort of say, are we willing to accept a patient or not? We do often, and the access team do this, they do recommend if the patient can afford to go privately, because they will get more regular input privately, but obviously not everyone can afford private health, even with the chronic disease management plans from the GP and things. And in those cases, we do still accept the patient, but unfortunately it's not ideal because we aren't seeing the patients regularly enough, ideally, to get the outcomes that we would like to have with these patients. So it is a gap that we're aware of, and unfortunately, yeah, it's a tricky one.
I think also outside of COVID, I mean, COVID times, I understand the continence clinic has really got a very limited capacity. But outside of COVID times, maybe we could have, like what we do with CRP, Michelle, that we will like create a plan, recognizing that there is a, CRP role and then the pain role, and then, how could we mix and match so then we can actually get the best patient outcome. So that might be something to look at in the future with continence as things go back to normal.
Yeah, I reckon that would be great. Like just even to have a combined plan of where to go for these patients, even to get that extra assessment. I don't know, Eddie, if you've got any thoughts about that, but
it would almost be great to have sorry to jump in there, it would be great to have a case conference for patients that are shared between the two services. I'd find that really.
Yeah.
And just to add to that as well, so why I sort of initially engaged with Marg is, so Marg works privately with the private practice that I work in once a fortnight. So she does all of the women's health stuff, obviously, because she's the guru. And I think that I initially sort of spoke to her because these people have so much complexity. So they come to the emergency department multiple times, and we get a referral from gynae saying there's no abnormality detected, and so does that actually mean that that have they been looked at in detail, like in that sort of that biosphere? Because from my point of view, like I couldn't actually interpret some of the the external internal examination that you had written, Marg. So I guess that that there is that complexity about these people, and that that it does need that that case management from multiple teams inputting.
Yeah, because I definitely think we've got a role to play in terms of the overall, persistent pain and those neurotags and education and graded exposure, and all of those principles are still very relevant, but there sort of does need to still be that key women's health physio assessment, just to get to some of that nitty gritty stuff that we just don't have the expertise.
Yeah. And I think that's what I wanted to bring out today. There is the pain side of things, which is pain. And, this is a pain team that understands how to manage that. But when you get to the nub of what these women are coming for, then you may need to think about where the expertise is going to come from. Now, thinking about the continence clinic, every continence and women's health physio who's been through formal training would have training in pelvic pain as well. So they may not be utilising that very much in the continence clinic, but they would have had that training in their postgrad studies. At least if they come through Melbourne Uni, they definitely would have. You could confidently send patients to a continence clinic. Maybe you have to be creative in your wording and your referral. And have your team and have those case conferences. I think that's really important then, because you're crossing between two services.
And probably to just butt in, hello, I'm Beck. I work at the Continence Clinic out in Lilydale, so certainly very familiar with Eddie and the team that work out here. The referrals I do get, they are beautifully well educated. Like, it makes my job investigating the really specific issues really quite easy, because they have got the knowledge about pain and about what could be contributing to their pain, and they're really great with those strategies. So certainly know that part is done really, really well. So we appreciate that. Thank you. And I take a lot of confidence in referring people across to you guys as well.
There was a question in the chat box before from Loris about referring to a psychologist when anxiety is present. I think, if I've worded that correctly, Loris. I think there was a question to you, Marg.
Just to clarify, I'm a little bit wary of doing a lot of relaxation work with people when there's a high degree of anxiety. I wonder if it's best managed by a psychologist. Just wondering what your thoughts are.
Oh, I totally agree. When if you've got a psychologist who has experience in pain, then their skill set is obviously far wider than ours as other conservative therapists. So yes, if you have one, that's a luxury that you should love and enjoy and utilise as much as you can. However, from working in the practice where Carlos and I work, they're talking to the pain psychologist there. Pain psychologists are actually very thin on the ground. It's not an area that psychologists go into very much. So if you get one, grab that person and keep them, nurture them.
Pain Matrix is recruiting.
Yes, we want another pain psychologist ourselves. So we need to find two, one for you guys, one for us.
So I think, Mark, the other reflection I had is that I really like that you made sure to make a point of that it all really links back, because I think that that we have patients, like all of our patients, I guess, coming from private practice that I've been in for musculoskeletal private practice. If you're not linking it back to the patient, then there's no it has an impact on their engagement. Obviously, it has an impact on what they're going to do for their homework and engaging with that. So I think that it's a really great point about how these things that they can't see that link, that you make sure that it's very much clearly linked for them. Why you're doing this kind of therapy for this grand goal that is very patient specific.
Absolutely, so that you save other physios saying to you, "Oh, this physio went to see a pelvic floor physio, and all I got was breathing and relaxation." Well, yes, that you need to link it back. Why am I doing shoulder stretches or back stretches? I've got a pelvic pain.
I really like the comment about your beliefs or your knowledge being like babies, like kids, and that you love your own. I think it's a really good reminder that we kind of have to very much do that perspective taking and work with where the patient is at, and kind of, understand their understanding and their beliefs. If we've got any chance of kind of manipulating or promoting another way of thinking about it, I think it's really, I took that away.
Yeah. I think that's really important, because one of the worst examples of that I had when I was working at the Women's was a lady who came to us with endometriosis, and she'd been on the medical model right from the early teenage life. She was now in her late 20s, and she'd had 28 laparoscopies to try and cut out the endometrium, the plaques inside her pelvis. And so the physio, one of my staff who was treating her, said, "Why didn't you come to physio earlier?" "Oh, I didn't need it any earlier." So she thought the only treatment for her endometriosis was to go and get it surgically removed. 28 surgeries. Can you imagine the scarring that she's living with for life now? So her belief to change to conservative therapies was a huge shift. So most of the treatment for a long time was just to change her beliefs.
Yeah, I think it also can help with avoiding staff burnout as well, because I think if you approach a consultation thinking that you know everything as well, and that you're kind of battling with the person to get them to change their beliefs, then it has the potential to kind of create even more of a fight and pushback, and ultimately a lot less effective than perhaps coming from a more, all right, I want to understand your understanding, and then maybe they'll be more, engaged in understanding your perspective, and it might actually be more effective and prevent burnout and fighting.
Yeah. And I think that comes with taking medications too. If they've been on drugs for so many years and they keep wanting to up the dosage. So I think we have to work really closely with our medicos so that any weaning off opioids is done together, not done separately, that we work as the team around reduction of opioids and understanding that opioids are less effective the longer you're on them. So yeah, all of that sort of stuff is required as well. We didn't go into meds at all today.
I just want to ask I was just going to ask if Sandra or Jeremy, if they wanted to, if they had any comments or questions. We just haven't heard from you guys.
I just want to say thank you. I really enjoyed the presentation. I'm obviously not a physio, so a lot of that was very, very new to me. I guess the only thing I want to mention is whether you see a correlation. Often people who have anxiety as one of the causes for these things are put on things like SSRIs, which tend to then cause sexual dysfunction, and it becomes a circular thing.
Yep.
Do you find that a lot? And also, I know there's a lot of topical things that is particularly for vulvodynia, moving away from just pelvic pain, and whether you have any comments on suggestions for those sort of things, because we often, every now and then, we get a pelvic pain patient and they're all sort of just treated as normal pain patients, which based on what I've seen today, doesn't seem like it, there are clearly other options for them.
Yes, so in terms of skincare and medications, there's some NDEP cream that's been trialled by the Women's. Ross Pagano invented it, you might say, and is now utilising it. Some women find that the cream in which the NDEP is, the base is irritative to the skin. So often if they go to a compounding pharmacist, they get it in gel. So it's an NDEP gel rather than cream, so amitriptyline gel. But otherwise, the trophic changes on the inner labia minora are just, if they really need to be treated well and slowly to be able to have the skin grow again over the roughened raw skin if it's been let go for too long.
I was going to add one thing I really gained as well is just knowing that we can refer. I actually didn't realise there's a women's health physio as an option. So that's really good to know as well. And I'll definitely, if I get pelvic pain patients, be recommending APS to look at that as well. So that's really good. Thank you.
That's good. I'm biased. I'm very conscious bias, not unconscious, very conscious bias that I think that's the right way to go.
I think it's just the last comment. So Sandra was put herself off her mute, and she was going to say that she had that the presentation was really great. It was very helpful and refreshing. The key concepts of persistent pain and all the considerations involved in it. So I guess we're probably 5 past the hour, so I probably should wrap up. Marg, thank you so much. This has been really fantastic for the pain team and also for for women's health in Eastern Health. I think it's sort of something that is an underrepresented skill set that hopefully now we'll be able to sort of tap. Vanessa.
That's right. Vanessa, Beck, you're expecting lots of referrals. Okay, it's been my pleasure, and I hope it's been glad it's been helpful. And feel free to contact me at any time, somehow, Google or via Carlos or anything else like that. I'm very happy to talk to anybody about pelvic pain.
Thank you, Marg. I will definitely pass on things and get your consent to pass on your details to people that are asking for it.
Okay, that's absolutely fine. Okay.
Right,
bye, everybody. It's been a
Thank
pleasure.
you. Thanks,
Thank you so much. Lovely.
Bye.
Bye.